All right, welcome to episode 11. And we are going to be talking about respiratory physiology and the ventilation and perfusion relationships. Now, just an announcement of why I'm here on a Saturday morning at 8 in the morning with you guys. So this month, really exciting. We're going to get Lahiru to come and have a chat to you guys sometime in the next sort of fortnight, just about mindfulness. And, you know, that I think that is really something that's come about in the last sort of couple of years. And I've realized the importance of that in being able to keep your mind in the most optimum shape possible. It's like keeping your body in the optimum shape possible for, you know, any sort of physical exercise. And this is a mental exercise. And, you know, it's something that, you know, we have thought about over the last couple of years. And Lahiru is certainly passionate about this subject. So we're going to come and get him to talk about you guys. And as part of that, I'm going to be donating sort of half the funds to his chosen charity, which is the Fred Hollows Foundation. And then the other half will still go off to the ANZCA Research Foundation. Now, the framework here is to really get you guys excited, get you guys, get the heart pumping to the brain, and to help you facilitate attention to detail and assist your brain in creating long-term memory for this exam. And when I say long-term memory, I mean for most of you guys till the March. So looking at 4 or 5 months, all right? How we're going to break down the SAQ today, we're going to review the examiner's report. And then after that, I'm going to show you the literature that I use to get the answers from. We'll present key concepts. I'll go through any sort of questions that you guys have after that. And I will create an answer structure and we'll all write an answer to time. Now, this is what we've gone through already from the primary ANZCA course about sort of 3 weeks ago. So we've gone through the importance of respiratory physiology, the control of breathing, the mechanics of breathing, which includes the muscle of respiration, the work of breathing, which includes compliance, resistance, and hysteresis, or the time dependence of pulmonary elastic behavior. This is all that's left to go through, so still quite a bit. We've gone through fast versus slow alveoli, physiological dead space, which is a component of both anatomical and alveolar. And we went through diffusion last week, and we're going to go through ventilation perfusion relationships, which includes a ventilation and perfusion. Pulmonary vascular resistance, we're probably going to leave for some time in the future, okay? But we're going to just touch a little bit on perfusion today, just to be able to answer this question here. Now, I've had a request from some of the patrons to skip a couple of these and head straight to aging and obesity, because these can be conceptually some of the harder ones. So I might do that just sometime in the future. All right, I'll let you guys know. Now, this is the question related to ventilation and perfusion relationships. It's from 2015 B, and the question is, what effect does placing a patient in the right lateral position have on lung ventilation and perfusion? The really nice thing about this question is that if you understand the concepts on how to answer this question, you can apply it to anything. So you can apply it into the left lateral position, you can apply it into the prone position, the supine position. The concepts are all applicable to all those different postures, and also whether the patient is awake or whether the patient is anesthetized. This is the examiner's report. Now, the question assumed that the person is breathing spontaneously with the right side down. And look, I always have a little bit of a criticism about the assumption. I think that if the assumption is, in other words, if the answers are not don't actually state that, you know, the patient is breathing spontaneously, it's probably because the question itself is not clear, okay? And I think that's something the examiners work on. So I think that, you know, in the future, there probably will be a lot more clarity in terms of the question, in case there's sort of any misunderstanding, all right? But for this, for all intents and purposes, we're assuming the person is breathing spontaneously with the right side down. Candidates needed to discuss changes to the ventilation, perfusion, compliance, and FRC in both lungs. These were best considered using separate headings. Perfusion and ventilation are both increased to the dependent lung by about 10%. Just with that figure there, that is important, but it's not quite right, okay? And I will show you why that it's not both ventilation and perfusion. It is perfusion, but ventilation a little bit less, and that will explain one of the diagrams that I'll show you later on. So perfusion and ventilation are both increased the dependent line by about 10% with better VQ matching as well. There is increased compliance in the dependent lung as the tissue is less expanded. The dependent lung corresponds more to West Zone 3, the non-dependent to West Zone 2. Extra marks were awarded for increased ventilation to the non-dependent lung in anesthetized or paralyzed people. So we do need to sort of mention about the state or what happens during anesthesia. Changes with an open chest, so during a thoracotomy, hypoxic pulmonary vasoconstriction, blood gas changes, time constants, and more detailed information on the main points. So actually lots to get through for a perfect answer. And I believe that the pass rate for this was 6%. So that's why this is a lot to get through. Now this describes what we shouldn't be focusing on. And I've highlighted this in red. Many candidates spend a lot of time detailing VQ relationships and West zones in the upright position without relating this to the lateral position, making it difficult to gain marks. There was some confusion over what side was dependent in the right lateral position. Marks were not awarded for details of one lung ventilation, positioning of double lumen tubes, surgical indications, risk description of the right lateral position, and detailed descriptions of dead space and shunt. Other issues were failure to relate the answer to the right or left lung, being imprecise when talking about compliance changes, repeating the same point multiple times. I think this is a very important sort of statement. Look, for difficult questions, that is something that candidates tend to sort of fall into in terms of sort of phrasing concepts, but in different ways, but it answers the same or describes the same concept. So that's something that we need to be aware of. And it's really about, I guess, knowing the breadth of information that can be put into the answer. And once you are able to acknowledge or realize what actually needs to be covered, this will help prevent you from doing this, all right? And that healthy people become hypoxic lying on their right side. So people, yeah. Finally, endoscopy is generally not performed in the right lateral position, all right? So things that we should not mention. And yes, healthy people do not become hypoxic lying on their right side. So this is a summary of the examiner's report of the question, what effect does placing a patient in the right lateral position have on lung ventilation and perfusion? To pass, we need to discuss in the spontaneously breathing patient, awake patient, the changes to ventilation perfusion, their compliance in FRC and VQ matching, and then the extra marks that you would get would be a discussion between the awake versus anesthetic state, whether they had an open chest and the role of hypoxic pulmonary vasoconstriction here, any blood gas changes, and time constants. This is the literature that I've used, and everything in my slides have come from here. Primarily chapter 7 from nuns, distribution of pulmonary ventilation and perfusion. I have used some of the text from Miller's, so chapter 13, Respiratory Physiology and Pathophysiology, chapter 53, Anaesthesia for Thoracic Surgery, Bunumov, Anaesthesia for Thoracic Surgery. I've used their images. This is a very classic test, and it's from 1994. It's one of the core texts that a lot of textbooks will reference to when describing their concepts. They'll describe it to this textbook here, okay? And then finally, I've used Slinger, Principles and Practice of Anaesthesia for Thoracic Surgery, chapter 5. For those who have listened to my podcast, my talks before, you know how much I try to avoid using textbooks outside the prescribed texts, but I have made an exception because, these two texts really do, I think, give some clarity to some of the concepts that Nunn's and Miller's describes. And I'll show you later on in the slides. Now, this is a really important slide that will allow you to answer any sort of question related to positioning and the distribution of a ventilation. So distribution of ventilation is affected by gravity, anesthesia, inspiratory flow rates, which are related to your time constants, and anatomy. So the right lung will always get a little bit more than the left because of where the heart is, okay? So the right 53%, left 47. You'll see different figures. You see it rounded up to 55 versus 45. So this is just these numbers are from Nunn's, but you will see them rounded off to 55 and 45. And I think that's okay to have that in the exam. And having sort of rounded numbers will also allow you to memorize these numbers a lot easier. Now, the intrapleural pressures is less negative at the bases due to the weight of the lung. And so at FRC, there's higher compliance at the bases and there's lower compliance at the apices. What you do for these concepts here is that you turn it around. So now the bases become the dependent lung and the apices become the non-dependent lung. All right, so the apices will become non-dependent and the bases will become your dependent. And you can see from this diagram here that now that in the awake conscious patient, that the dependent lung now functions on the most compliant part of the curve and the non-dependent lung functions on one of the least compliant parts of the curve. Again, at FRC, there is a lower resting volume at the bases because of the weight of the lung, and there's higher resting volume at the apices because of the traction from the higher negative pressures pulling out the lung. And you can again apply this to the lateral position. So again, the bases are your dependent, and so there's lower resting volumes in your dependent lung, and your apices are your non-dependent, and then there's higher resting volumes in your non-dependent lung. Now, in the lateral position in the conscious patient, what you find is that FRC in the dependent lung is less than the non-dependent lung. So in other words, the bottom lung will have less FRC than the top. And this is due to the weight of the abdominal contents pushing the diaphragm of the dependent lung higher. And hopefully that makes sense to you. So let's say you've got two lungs here, you've got the dependent lung here, and you've got your abdominal contents pushing this one up, decreasing FRC. But the benefit of this is that, as you can see, because this is pushed up, this allows for contraction, for more efficient contraction, which helps contribute to the increase in ventilation. So not only do you have the dependent lung functioning on the compliant part of the curve, but now you're describing that it's got more efficient contraction of the diaphragm. And if you look at the top lung or the non-dependent lung, you can see that it's got an increase in FRC, but the diaphragm is a lot flatter. So its contraction is less efficient. This is the table from nuns. This is where this question has all come from, okay? Now, this is a busy table, but what we're gonna do is just focus on the green boxes here. And this box here, sorry, the top number here describes the FRC, the relative FRC, all right? And then what happens is that now the FRC sort of changes with that positioning. And then the bottom lung describes the distribution of ventilation. What is interesting is that despite describing that previous concept where FRC is reduced with in the lateral position, you can see here that, look, in the right lung, you've got FRC of 1.69, but on the dependent lung, it's only 1.68. So it doesn't actually change that much. But you can see that the left lung, which had an FRC of 1.39, really increases to 2.07. So the relative efficiencies of contraction are that the dependent lung, which is the right here, is a lot more efficient than the left, okay? And that is evident in the change in ventilation. So we've gone from, in the supine position, 53% to an increase in 61%, all right? And that's plus 8%. And on the left lung, we have 47% going down to 39%. So that's minus 8%. Now, these numbers are a little bit hard to remember because you'll have to apply this to the left lateral. And so I've created like a rule, which is the plus minus 7% rule, okay? And you can look at this yourself, but the reason why I've done this, it just allows me to make it easy for me to remember, because otherwise it's a lot more complex. Because I can give you an example here, because when you look at the left lateral position, what you have here is that the right lung goes from 53 to 47. So that's minus 6%. Okay, whereas when you look at the left lung, it's gone from 47 to 53, and that is plus 6%. And and then after that, we're going to go through what happens during anesthesia, and again, it's within that sort of it's within the 7% range. So I think that's why when you look at this table, I hope that it will hope that you'll understand why I've chosen plus minus 7% as the general rule in terms of what happens when you go from left to right, as well as what happens when anesthesia occurs. Okay, and the next couple of slides will show why this plus minus 7% is actually quite useful. The starting numbers that I have is 53 and 47. But again, if you want to memorize it as 55 and 45 and then use this plus minus 7% rule, you can do that. And again, remember that this plus minus 7% is different from that that 10% change that was described in the examiner's report. All right. So this is already one sort of concept which differs from what the examiners is saying. And I'll show you that other diagram, which will really sort of hammer in home why the change with ventilation and perfusion is not 10% each. Now, during anesthesia, the compliance changes so that the dependent lung is now much less than the non-dependent. And this is due to further reduction in FRC in the dependent lung from loss of tone in the chest wall and diaphragm, and also due to atelectasis. In other words, if you look at the dependent lung here, okay, because of the loss of tone in the chest wall and diaphragm and atelectasis, it's now moving from the compliant part of the curve to the other non-compliant part of the curve, which is down the bottom. And the top part of the lung, the non-dependent lung, is now moving to the compliant part of the curve. The really nice thing about even though this concept can be a little bit difficult, what makes this, I think, easier to understand is that it's independent of the mode of ventilation. And that's really nice, because what that says is that it doesn't matter whether the patient has been anesthetized as a spot vent GA or as paralysis, the changes are the same, okay? And I'll show you that in the next couple of slides. Now, the concept here is that now, because the non-dependent lung is functioning on the compliant part of the curve and the dependent lung is functioning on the less compliant part of the curve, your ventilation is now more in your non-dependent versus your dependent. All right, I'll show you. And these are the boxes here which are gonna show that. So again, you've got the conscious patient in a supine position. And what happens is that during anesthesia, all right, so we're going right lateral, which means that your right side is your dependent side. And you can see that from 53%, we've gone down to 45% and 44%. So that is a change of -8 and -9%, okay? And this is for the spontaneously breathing patient and for the IPPV. Now, if you look at the left lung, again, you can see that this is +8 and this is +9%, all right? And you can do this exercise for over this side, but you can see that over this side, there is a much wider range. In other words, you've got, so that is, and if you've got the left lateral side, which is your right side up, it means that now your right side is your non-dependent, which means that, remember that when it's the non-dependent during anesthesia, it will get more of the ventilation. So this side will increase, but you can see this side increases by 3% and increases by 7% here. Whereas your left lung, when you've got in the left lateral position, in other words, your left lung is now your dependent side, it decreases by 3% and then decreases by 7%. And you can see all these different numbers, and that's the reason why I've chose this ±7% rule, because I think that will allow me to create scenarios which will be easy enough for me to remember. So in other words, I start off with 53 and 47, and then if you go from a right lateral in the conscious position, what I know is that the right lateral means that the right side is your dependent lung, and that will increase in ventilation. So I'll +7 here. Okay. But during anesthesia, I know that that will reverse. And so I will -7% from this figure, okay? Same thing again. So the left lung, if you're in the right lateral position, you'll have -7% here. And then during anesthesia, I will +7% here. Okay. And those are just sort of easy ways for me to remember the changes both in posture as well as during anesthesia as well. Now, during a thoracotomy, so during thoracotomy, the compliance in the dependent lung is now much, much less than the non-dependent. And this is due to even further reduction in FRC because of the negative intrapleural pressure holding the mediastinum is lost. In other words, once you open up this chest here, you lose that negative intrathoracic pressure. So you lose it. And often this negative intrathoracic pressure will actually hold some of the contents in the mediastinum. And when you lose that, this pushes down, which further decreases your FRC, which further pushes your dependent lung further down into the lower part of the compliance curve. And so what that means is that when you do thoracics and you have an open chest and you have someone on 2-lung ventilation, so you haven't isolated yet, what will happen with the mechanics is that with the ventilation, it will preferentially ventilate the top lung or the non-dependent lung because of this concept here. And so the way that you reverse it or the way that you optimize it is to initiate one lung ventilation. So with one lung ventilation, you're only ventilating the dependent lung, and then the use of PEEP as well will help move the compliance of the dependent lung further up this compliance curve. So those are the techniques that you would use to help improve compliance in the patient who's having a thoracotomy with an open chest with the dependent lung. Okay. And this is the distribution of ventilation here. So this is a patient who hasn't had one lung isolation. So they've got an open chest, and you can see here that this is in the left lateral position. So the right side is the non-dependent side, and on the non-dependent side, a lot of that ventilation heads up there. Okay, because the dependent lung functions on the very, very low part of the compliance curve. Now, we've talked about the effect of gravity and anesthesia on compliance in the lateral position. So now we're going to talk about inspiratory flow rates. For normal flow rates, the ratio of ventilation of upper to lower is 2 to 3. In other words, your lower lung will always have more ventilation than your upper lung at normal flow rates. And that actually works out quite well in terms of optimizing VQ matching. However, at higher flow rates, the ratio of ventilation approaches 1 to 1. And the reason for this is because of the regional differences in airways resistance. All right, because the lower airways have a much longer way to go to the alveolus. And when you increase your flow rate, you're going to be increasing the airways resistance. And what will happen is that the resistance in the lower airways will be a lot more than the upper airways. And therefore, the distribution of ventilation will be a lot more uniform. The benefit of this is during exercise. So during exercise, where you are having much higher flow rates, you want to have a more uniform spread of ventilation to match the increase in perfusion in your lung. So during exercise, where you've got increased perfusion, both your basis and your apex will start increasing through recruitment and distension. And this provides optimal VQ matching again. Now, I want to have a little bit of a caveat here that when we talk about exercise, you don't just increase your flow rate, but you increase your volume as well, all right? And I think that is really, really important to sort of understand because when we sort of talk about time constants and the distribution of ventilation, a lot of the examples that you hear with time constants, it's for a given volume, okay? Whereas what we're talking about here is, during exercise where we're increasing the volume as well as increasing the flow rate as well. And I think knowing that will help you reconcile some of the concepts, but because if you think about this, when we think about the alveoli in the apex, so let me go back. Yeah. When we think about the alveoli in the apex, what we are saying is that they are starting off at a much higher volume, and that's why they've got lower airways resistance. But when you start off at a higher volume, it means that your ultimate change in volume is actually much less than the alveoli at the bases, which start off at a lower volume, okay? And so even though the distribution of ventilation for a given volume can be more initially at the apex, when you look at it in terms of totality, if you're having much higher volumes, you're still going to get a lot more of that volume head off to the bases. And that's just another sort of layer of complexity to that concept there. All right. Now, if there's any questions, I want you guys to write this down because I'm happy to go through this again. Now, we're just going to review sort of last week's concepts on time constant. So a fast alveoli has low compliance and low resistance, and a slow alveoli has high compliance and high resistance. And in a conscious patient, what is often described is that the apex or the non-dependent lung is almost analogous to your fast alveoli because they've got low compliance and low resistance. In other words, low compliance, and because they function on a higher volume, they've got low resistance. Versus the dependent lung or the bases, they've got high compliance, so they're on the high compliant part of the curve, and they've got higher resistance because they're further away from the mouth. And so they are often sort of similar to slow alveoli, all right? And this is the slide again from last week. We know that alveolar units with different time constants, in other words, increased heterogeneity, the distribution of gas is dependent on the flow rate, duration, and frequency of inflation, where you get preferential filling of fast alveoli, which is represented as an increase in your P1, which ultimately affects also your peak pressures as well. Now, for a given tidal volume, so for here, I'm just saying that the tidal volume is fixed. I'm not increasing the tidal volume as I would in exercise. Increasing frequency or decreasing the duration of your frequency. In other words, you're increasing your inspiratory time and subsequently increasing your flow rate. What you'll see is that there'll be an increase in ventilation to the non-dependent lung, so that distribution becomes uniform. And that is that sort of similar concept to what happens during exercise. So when you increase your inspiratory flow rate, your distribution becomes more uniform because more proportion of the ventilation is now heading off to your non-dependent lung. The question is this the same for under anesthesia? So remember, this is for a patient who's conscious. Let's have a look at it. For under anesthesia, again, here are the rules. Fast alveoli equals low compliance and low resistance. Slow alveoli equals high compliance and high resistance. In anesthesia, what is it on the non-dependent? Let's work it out. So the non-dependent now has high compliance. Okay, so the non-dependent has high compliance, but it's got low resistance. Whereas the dependent lung, if you look at it, has low compliance, but high resistance. And I'm sure it's obvious to you now that when you look at these two time constants, they are the same. Okay. And therefore, during anesthesia, in the lateral position, when you think about the regional differences between the dependent and non-dependent lung, what you'll find is that the idea about increasing inspiratory flow rates and time constants actually doesn't have that much of a change in terms of the distribution of ventilation, as it would in someone who is spontaneously ventilating. Okay, remember that someone who's spontaneously ventilating, this concept can hold true, but for someone who is under anesthesia, the time constants of both the dependent and non-dependent lung, they're almost the same. And this is the concept when we're sort of relating it to sort of regional differences. What adds that layer of complexity is that time constants are often not just used for physiology, but more commonly used for pathophysiology. In other words, the heterogeneity of the lung units themselves. And that's where it gets quite complex, because when you read NUNS, they do apply time constants to physiological regional differences, which is what I've done here. But then it's also applied in pathophysiology as well, okay? And that's why it can be sort of quite complex understanding this. But I think that the best way to reconcile it is know that it can be both defined, time constants can be both applied physiologically in terms of the regional differences in terms of apex versus bases or dependent versus non-dependent, and also in pathophysiology as well. Now, what about perfusion in the lateral position? So this is where it actually got quite hard to find some of the information in NUNS. Now, this is a summary of NUNS in chapter 7. What we know is that the adult thorax has a diameter of 30 centimeters, and the height of the lung is approximately 25 centimeters. So from here to here is 25. And when we think about it across from left to right, it is 30 centimeters. And so it exerts a hydrostatic pressure in relation to mean pulmonary arterial pressure. Doesn't matter whether you're supine or in the lateral position. But when you're in the lateral position, what you are assuming, okay, so let me just draw my two lungs, is that the upper lung will now correspond to zone 2, and the lower lung will correspond to zone 3. Now, in the conscious patient, what we have here is preferential ventilation of the dependent lung, and that actually corresponds with increased perfusion. And so the VQ ratios are not greatly altered. And this is the figure 5.8 from West. And this is what I was talking about in terms of going from bottom to top. You can see that the difference in perfusion is a lot more than the difference in ventilation. Okay. So the difference in perfusion between bottom and top is about 10%. And the difference in ventilation from bottom to top is 7%. So I think this is the second concept, or the second reason why that initial statement that both perfusion and ventilation would increase or change by approximately 10%. It's not quite true. Blood flow, yes, changes by 10%, but ventilation changes less, by about 7%. And again, the analogy here, this is for the upright patient. This is upright patient. And what we're going to do here is that we are going to apply it to the lateral patient so that the bottom here becomes the dependent and the top becomes the non-dependent. And a couple of things about this diagram to draw it correctly. So you've got the dependent or non-dependent, or the bottom and the top on the x-axis. The VQ ratios are on the other y-axis, okay? And you can see that the VQ on the top, the number that you will often see stated, or the number that you should try to recall, is that the VQ on the top is 3.3. The VQ at the bottom is 0.69, okay? And what you have on these axes here, you've got liters per minute as percentage of lung volume. This can be a little bit confusing, and I'm going to be honest with you, I'm not 100% sure what it actually means. I think it means that it is the amount of either ventilation or blood flow for a given percentage of lung volume. The only reason which is why this is a little bit confusing is that if you look at some of the studies and you look at the flow with ventilation and perfusion with the MRI or the SPECT studies, or it's often done with density, and the lung is certainly a lot more dense at the bases than it is at the top. All right, so I'm not 100% sure how to sort of explain this, but I can say that when candidates do draw this diagram and when examiners do sort of ask for this diagram to be drawn, they don't really examine sort of too much on how this axis or how the labeling is done on these axes. And you'll see it drawn in a lot of like memory cards or flash cards. They'll just have liters per minute of lung volume or something along those lines, and they actually won't have the units there, because the main concept that needs to be described here is how blood flow changes with gravity, how ventilation changes with gravity, and that with blood flow it changes more compared to ventilation, and then after that the VQ ratios that occur between the bases and the apex, or the dependent versus the non-dependent. Now, with the anesthetized patient, as previously described, there is preferential ventilation of the non-dependent lung, but there's no change in perfusion. And so this ultimately leads to VQ mismatch. Now, if you were asked to draw what would happen, okay, in someone with someone who's ventilated onto this graph here, what you would draw is a pivot, okay, where the graph will look something like this for ventilation. Right, this is under anesthesia. So in other words, what you're saying is that there's preferential ventilation of the apex versus the base for someone under anesthesia. And that would be a very conceptual application of the concepts that we have described. All right. But the blood flow doesn't change. The blood flow remains the same. And that's why there's VQ mismatch during these cases. This is the diagram that you'll see in nuns, which talks about sort of the same concept as well. The reason why it's confusing is also because of this. So they've gone from cranial to caudal, in other words, from top to bottom, whereas West has gone from bottom to top. All right. And they've also shown upright, supine, and prone, whereas this one here is only for the upright position. And this is the VQ ratio. So you think about, this is the VQ ratio that is representative of this one here. All right. The other thing that's confusing is that they've also drawn West Zone, what happens at West Zone 4. So you can see that as you head down, your perfusion starts to drop off, and due to West Zone 4, and also that sort of correlates with the ventilation, somewhat with the ventilation as well, okay? And when you look at the West one, they've actually excluded West Zone 4. All they've drawn is this one here for the perfusion, and then this one here for ventilation, all right? And again, on the x-axis here, I believe that these x-axes are ratios of the average. All right. So in other words, what they've done is that if this is the average here, what they're saying is that the base here has X amount compared to the average. So again, the x-axis, and I think that's why, the y-axes are not well defined, and I think that's why the y-axes probably, when you're asked to redraw these diagrams, are probably of less importance in terms of being able to sort of label them and sort of have the appropriate units there. Okay, one of the few times I think that you probably don't need to have the exact units there. Just with, I think, the complexity and vagueness of what the y-axes actually are. Now, in Miller's, it says that blood flow to the dependent lung is increased by 10% compared to supine. And look, when I had this question here, and I think what we've all come to agreement with is that when they talk about 10%, they're talking about an absolute value. But again, you know, this is where I wanted to really make sure that we weren't talking about a relative change, we're talking about an absolute change. And I think, you know, sometimes the language used in textbooks can sort of create that level of complexity, because I can totally understand how a candidate may interpret that sentence as a relative change. So this is why it's an absolute change, and this is why I think it's good to sort of use another textbook. So this is a summary from Slinger. What it says is that the gravity-dependent distribution of flow is maintained with anesthesia, with a roughly 10% shift of cardiac output to the dependent lung. And so in the right lateral position, and what it assumes here is that the right equals 55% and the left equals 45%. All right, this is normal. So normal supine position. So normal supine position, the right has 55, the left has 45. And remember that in nuns, it's 53 and 47. All right, so again, that's why I said you see those sort of two figures around, which I think is fine. In the right lateral position, this goes from 55 to 65, so plus 10, and this goes from 45 to 35, minus 10. And in the left lateral position, this goes from 45 to 55, and this goes from 55 to 45. So just to summarize the thing, just to summarize what I said, perfusion changes by plus minus 10%. Ventilation changes by plus minus 7%. All right. This diagram here describes the importance of hypoxic pulmonary vasoconstriction. And what it's saying here is that the dependent lung has 60% of blood flow and the non-dependent has 40% of blood flow. The QSQT represents the shunt fraction. And what it's saying is that there is an equal distribution between the non-dependent and dependent for the shunt. So in other words, that the non-dependent contributes 5% shunt, the dependent contributes 5% shunt, which explains this. And therefore, 35% of this is non-shunt blood and 55% is non-shunt blood. And during one lung ventilation here, if you didn't have hypoxic pulmonary vasoconstriction, what that would mean is that your shunted blood would be in totality 40%. But what hypoxic pulmonary vasoconstriction does is, with this 35% of non-shunted blood, it is able to reduce this by 50%, okay? So that the fractional blood flow becomes 17.5%. And what we're doing is we're adding the physiological shunt that's there already. So that's another plus 5. And that will equal 22.5. So without hypoxic pulmonary vasoconstriction, this would be a 40% shunt. Without hypoxic pulmonary vasoconstriction, that would equal a 40% shunt. With hypoxic pulmonary vasoconstriction, it's able to reduce that to 22.5%. And you can, this is one of the core diagrams you'll see in Barash clinical anesthesia. And this is the newer version, 2013, but you'll see also the one in 1994 as well. All right. Now with hypoxic pulmonary vasoconstriction, you don't need to memorize this formula, but I think it is important to know that it's not just partial pressure in the alveolus that causes hypoxic pulmonary vasoconstriction, but it's also a component of mixed venous oxygen as well. The primary component is obviously the alveolar oxygen, but you'll see also that, conceptually that the mixed venous plays a small role in it as well. Now, the benefit of hypoxic pulmonary vasoconstriction is that it allows for better VQ matching. And these are the factors that either attenuate it or augment it. It's just a summary. So it's attenuated by intravenous iron for at least 43 days. So just be, I guess, conscious of any patients who have had an iron infusion prior to thoracotomies. It's also attenuated by alkalosis and hypothermia. And conversely, it's augmented by acidosis and hypothermia. All right. Now, you might be asked to draw a PO2 or PCO2 diagram, and it's more sort of specific for the Viva, but I'll go through this with you to sort of help you understand the construct of how this diagram comes about. And what we have here is that we've got this point here and this point here. This point here represents shunt. This point here represents alveolar dead space, okay? Now with the shunt, it represents your mixed venous blood. And with your mixed venous blood, it means that your PO2 is 40 and your PCO2 is 45. Over here, you've just got alveolar gas, which means that your PO2 is 150 and your PCO2 is 0. The bases of your lung, all right, function at this point here, and the apex of your lung function at this point here. Remember what I said, the apex has a VQ of 3.3 and the base has a VQ of 0.69. Now you will see, and you might get asked as well, what are the relative PO2s and PCO2s in the bases compared to the apex? And the numbers that you will see is that the PO2 in the base is 89, and these figures are from West, and the PCO2 is 42, and the PO2 here is 132, and the PCO2 here is 28, all right? These numbers are hard to remember. The only reason I remember them is because I've done this for X number of years, but I'm gonna show you a really, really easy way for you guys to remember this. It's not gonna be as exact as this, but it's gonna be pretty close. And I think that, and that is actually more than enough for this exam, all right? Now, I'm sure some of you clever guys already have sort of worked out that if you pump this number into the alveolar gas equation, you actually don't get this, okay? So if you put this in the alveolar gas equation, you actually don't get that, all right? What I haven't included here is the change in nitrogen. So there is a change in the nitrogen partial pressure, which explains why the numbers that you'll see here don't sort of fit into the alveolar gas equation. All right. So if you do get this question in the Viva, and you're asked why do those numbers don't correspond to the alveolar gas equation, the answer to that is that there is also a change in the partial pressure of nitrogen with the bases compared to the apex. And you can see the differences in a diagram, in one of the diagrams in West. All right. Now, this diagram here explains that here, this is shunt, and this is alveolar dead space. And that, I want you guys, when you define shunt, I want you to define shunt as relative to blood, okay? Don't try to describe shunt in terms of the alveolus, because what I'll often hear is that shunt is blood that passes through the alveolus that doesn't participate in gas exchange. Whereas shunt can actually be blood that passes from the right to left side of the heart without participating in gas exchange, because that also includes congenital shunts, all right? So try to define shunts in terms of the blood, and then you can define alveolar dead space in terms of the alveolus. So alveolar dead space is alveolus that is ventilated, but does not participate in gas exchange. And I think doing it that way will just allow you to understand sort of the differences between them both. All right, because otherwise I think it gets conceptually quite hard. Now, this is how I want you guys to be able to sort of draw this diagram here. All right, so use this diagram from West as the base, and this is what we're going to do. So you've got your PO2 on the x-axis, you've got your PCO2 on the y-axis, and you're going to label it 40, 60, 80, 100, 120, 140, and you can put 160 here. And again, 0, 20, 40, 60. The important numbers are between 140 and 160, between 120 and 140, and between 80 and 90. All right, sorry, 80 and 100, which is 90, between 120 and 140, which is 130, and between 140 and 160, which is 150. And so therefore, you know that this spot here is your alveolar gas, which has a PaO2 of 150 and a PCO2 of 0. This is your mix of venous, which is a PO2 of 40 and a PCO2 of 45. All right, so this is 45 here, and that's the other number you have here. Now, on your y-axis, the important numbers here is 30, and between 40 and 45, which is around sort of 42. Okay. And therefore, these are how the numbers match up. 42 will match up with 90, 30 will match up with 130. And this will represent your apex, and this will represent your base. So your apex will have a PO2 of 130 and a PCO2 of 30. Your base will have a PO2 of 90 and a PCO2 of 42. Okay. This would be the pattern in order to generate these numbers here. And let's practice it. So grab your pens, and we're gonna practice drawing this diagram together, okay? Yeah. Here. If you asked to draw this diagram in the exam, PO2, PCO2, got 20, 40, 60, 80, 100, 120, 140, 160. Again, 20, 40, 60. The important numbers here are 150, 130, and 90. And we're going to start from 40 to 45. And we need to draw it all the way down here. And we know that the spot here is 30. So 30 will match up with 130. 90 will match up between 40 and 45. So it's 42. Okay. And then what you say is that your base will represent this spot here, which is 90 and 42. And your apex is going to be here, which represents 130 and 30. Okay. And then this is your mixed venous point, and this is your just your inspired alveolar gas of oxygen, which is 150. Great. Hope that makes sense. Now, we'll go through the structure, which I think I'll use for this answer. So I'll define which side is the dependent and non-dependent lung. And the changes are due to gravity, anesthesia, inspiratory flow rates, which are where we can sort of describe time constants. But the challenge with this is that we also want to talk about awake versus anesthesia and all these things. So the ventilation, perfusion, compliance, FRC, VQ matching, blood gas changes, as well as the open chest and hypoxic pulmonary vasoconstriction. And conceptually in my head, I would think that what I would do is I would define which side is dependent, non-dependent, and I would probably have my core headings as awake, anesthesia, open chest on each page. And within that, I would have the chain, like these ventilation, I would have ventilation, I would have perfusion, and I would have probably something on VQ matching. And then within each one, I would talk about why ventilation changes. So that could be due to gravity or primarily gravity, and how that affects the compliance, and how anesthesia affects the FRC. And then I would describe the inspiratory flow rates and time constants, probably only for the awake patient. I probably wouldn't add it in for the patient who's undergoing anesthetics. And I would probably have the blood gas changes as part of a diagram that I would draw for VQ matching. Okay, I'm just trying to think about conceptually in my head, and I think that will work. All right, I think that will work. All right, guys, you guys and I want you all guys to have this exam paper here. If you don't have the exam paper, email me. I'll email it to you. It's really good to practice it. All right. Okay, you guys ready? Our 10 minutes starts now. All right. So I'm just gonna have my definition. I'm gonna have the awake here. Emphasize for economy. Okay, I'm just going to define first. So I'm going to say that the right lung equals the dependent, which is analogous to West Zone 3. The left lung equals non-dependent, which is West Zone 2. So in the awake patient, lung compliance, you know that dependent is more than non-dependent due to gravity. Just draw my little volume, pressure. So dependent, non-dependent. Okay, so the distribution of ventilation, we're going to go from 53% to 60% in the dependent, and 47% to 40% in the non-dependent. 1, 2, 3. Distribution of perfusion due to gravity. We're going to go from 55% to 65% in the dependent, and 45% to 35% in the non-dependent. Leads to VQ matching similar to supine. And just quickly draw this graph here. So we've got the VQs, just liters per minute. Just go dependent, non-dependent, perfusion, ventilation. Okay, I can go here. Non-dependent, VQ equals 3.3, and dependent, VQ equals 0.69. You can put, I guess I'm going to put other figures here. PO2 is 132, PCO2 is 28, PO2 here is 89, PCO2 is 42. And then the fourth thing here is increasing flow rates, increase ventilation to non-dependent lung, fast alveoli, compared to dependent lung, which is your slow alveoli, so that distribution is uniform. However, leads to VQ mismatch. Right. With anesthetics, lung compliance dependent is less than non-dependent due to a decrease in FRC from loss of tone and atelectasis. Again, I can draw a little diagram here. Pressure, volume, compliance curve. And what I'll do is so non-dependent, and this is your dependent. Okay, so distribution of ventilation, which is independent of mode of ventilation, i.e. no difference with spot vent GA or IPPV. What you have is that you're going from 55% to 48% independent, and you're going, 53, the maths is wrong, 53 to 46%, and 47% to 54% in non-dependent. And then distribution of perfusion is similar to awake, leads to VQ mismatch, leading to decrease PaO2. Thoracotomy. So thoracotomy compliance in dependent lung significantly less non-dependent lung due to further decrease in FRC from loss of intrapleural pressure, holding the sternum, reversed with one lung ventilation and hypoxic pulmonary vasoconstriction increases perfusion to dependent lung and needs to increase ventilation to dependent lung, and both lead to improved VQ matching. Okay, the mediastinum leads to non-dependent preferentially ventilated. All right, that is 8, 9, 10 minutes. Now, looking back at my answer, one of the, and this is what I think it's a really important exercise. I look back and I go, look, what actually did I spend a lot of time on? I actually spent a lot of time, I think, writing dependent and non-dependent. I think I've done that like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, like about 12 times. And I think that if I was to do this question again, what I might do is I might define dependent as D and non-dependent as ND, just to save a bit of time. Hopefully, yes, I need to go get organized, need to get some flowers, and the kids want to do some piñata for her. So but she's an endocrinologist, so we can't have sweets. So I think that the kids have thought like maybe Brussels sprouts. I know. Woe is me. All right, guys. Thanks so much for joining, and shoot me off an email if you have any questions. It is going to be busy. It is going to be busy this weekend, but I will try to have this up in the next sort of 24 hours after tonight. Okay. Good stuff.